No.
Very good evening, everyone, and welcome back to the Pediatric Spine Academy webinar series. This time around, we have a very interesting topic, that is selective thoracic fusion, where we just try to fuse a part of the spine in a scoliosis, planning that the next part corrects itself. So Pediatric Spine Academy is a organization we all know that is based on creating awareness of pediatric spine problems. This time we have Dr. Ajoy Shetty from Ganga Hospital. We all know him. He is a prominent faculty in most of our conferences and a great speaker. So over to Dr. Ajoy Shetty to give us insight about how can we think about selective thoracic fusions when we get such a patient. Over to
Hriday,
you.
thank you. I'll butt in for a second. The plan for today's meeting is that we'll have a keynote lecture by an expert. That's Dr. Ajoy Shetty. Once we get to know, the nuances of STF, selective thoracic fusion, we have 4 cases to be discussed, and some of our younger faculty will discuss those cases. And these will actually help us translate the knowledge that we've got from this keynote address into real life situations. And we would like everyone to participate aggressively so we can get enough juice out of today's webinar. So thank you, Hriday, and Ajay, thank you. Over to you.
Thank you, Abhay, and thank you, Hriday. You can see my slides, right?
Yeah, very well.
Okay. Good evening to all of you, and thank you for joining. My talk will be on selective thoracic fusion, why, when, and how. The goals of surgery in scoliosis is basically to restore coronal and sagittal balance. We know that scoliosis is a lateral curvature along with rotation. We try to make the spine straighter. It's also important to achieve a shoulder balance and prevent truncal shift, and to avoid curve decompensation and recurrence of the deformity. And this is what we can do by doing a long segment fixation involving all the structural curves, so that you get a relatively straight spine on the coronal and also a good sagittal balance. But however, we do know that long fusions over a period of time can cause degeneration of the disc, and also it can cause other problems like facetal degeneration. And therefore, it's very, very important that the unfused distal segment should be as short as possible. Studies have shown that the amount of degeneration varies depending upon the number of free lumbar segments. And when you have done a fusion extending up to L4, there is a loss of spinal mobility. Most commonly, if you ask a child, they may not be able to touch the toes. There are greater incidence of low back pain as age advances over a period of 20 to 30 years follow, increased perception of trunk rigidity and negative effect on the quality of life. We had looked into the changes of disc at around 10-year follow-up. We didn't find anything significant. However, we should remember that majority of these children who may operate are between the age group of 10 to 14 years, and they may not have significant problems at 10-year follow. But when you see them at around 20 to 30 years, and that's where the problem of disc degeneration, the back pain, everything tends to set in. Therefore, it's important for us to understand that one of the most important goals in scoliosis is also to save the motion segment whenever it's possible. The aim should be to have a coronal and sagittally balanced spine, but at the same time, if possible, try to save as much motion segments as possible. Therefore, when you take a fusion in adolescent idiopathic scoliosis, especially a thoracic curve involved, that is in a Lenke classification, type 1, 2, 3, and 4. It is called as non-selective when we do the fusion below the level of L2, and selective when the level LIV at the last instrumented vertebra is L1 and above. Therefore, this is how the difference between selective and non-selective. Therefore, when you take selective fusion per se, you can divide them into selective thoracic fusion for type 1 to 4 curves and selective lumbar fusions for type 5 to 6 curves of Lenke classification system. Basically, to explain, when you have got 2 curves, the thoracic and the thoracolumbar curves, both have deviated from the midline. If you use only the major curve, for example, the thoracic curve in this picture, leaving the minor curve unfused and mobile, The whole idea is to keep the lumbar curve as mobile as possible. The concept is not something that is new. Actually, when the King and Moore classification was put forward, since that time, the type 2 King curves, people used to do a selective fusion. That means when both the lumbar and thoracic curve cross the midline, the thoracic curve is greater than the lumbar curve. The lumbar curve is more flexible than the thoracic curve. You fuse only the thoracic curve. And this concept was done way back in 1980s. But if you look at the practice of surgeons throughout the world, I mean, this is a paper which came out around 8 to 10 years ago. Maybe the percentage has become more now. Only 49% of the patients in multi-center series were treated by selective thoracic fusion. There is concern in regards to patient, concern with regards to the surgeon, because you have to do an undercorrection. That's number one. Number two, there is a higher chances of problems of adding on. Therefore, the spine doesn't look that much straighter. There could be adding on and compensation. And that's why still a lot of us, whenever there is a doubt, we tend to go for non-selective fusion, going up to the stable vertebra down in the lumbar spine. Because there are problems with selective thoracic fusion, the decrease in the amount of deformity correction, risk of adding on, and risk of decompensation. Therefore, this is why we have to do a selective thoracic fusion. The next important question is when we have to do a selective thoracic fusion. We can do selective thoracic fusions in cases of Lenke type 1C, 2C, and 3C curves. You may do selective thoracolumbar fusion as understandably in Lenke 5 and Lenke 6 curves. Therefore, if you take Lenke 1C curve, by definition, what does it mean? The main thoracic curve is structural and the lumbar curve crosses the midline but is non-structural. Similarly, it applies to 2C curve. Therefore, what we are going to do, as per the principle of scoliosis correction, all the structural curves needs to be fixed. When you say a Lenke 1 curve, that means the thoracic curve is structural, and the C means the lumbar modifier is crossing the midline. But basically, when you are doing a selective fusion, you are fixing only the structural curve. Whereas when you come to 3, in type 3, both the curves are structural, the thoracolumbar and the lumbar curve. You have to be very, very careful when you are doing a selective fusion. The radiological and the clinical criteria, which I am going to discuss later, which is based on the Cobb magnitude, AVT, AVR, has to be very properly met before you decide that you will be able to do a selective fusion in a type 3 Lenke curve. Therefore, how do you determine when you can do a selective fusion? You have clinical factors and you have radiological factors. It's always important to examine the patient in detail. You have to look at the shoulder level. You have to look at the prominence of the thoracic and the loin prominence, the rib hump and the loin hump. This basically, what does the hump imply? The hump implies that there is a rotation of the vertebra and the severity of the rotation and the structurality of the curve. You should also look for trunkal balance. A highly imbalanced trunk, you should not try to do a selective thoracic fusion. It's always safer to go down to the stable vertebra. Therefore, after surgery, you are able to balance it. If there are signs of ligamentous laxity, you have to be extremely careful because these children are more flexible. The chance of adding on becomes significantly more. Let's see the examples. Like this girl has got a left thoracolumbar curve. As you can see, that there is a prominent hump on the left side corresponding to the curve. But however, even though there is no prominent thoracic hump, there is a prominence of the scapula, but more importantly, the right shoulder is at a higher level. This implies that the proximal thoracic curve is structural, and you may have to include both. Your fixation may go up to T2 or depending on the curve measurements. Similarly, in this girl, the left thoracic is structural, and therefore you have to look at the shoulder level, look at the rib prominence, look at the loin prominence to decide whether I am going to do a selective fusion or not. Again, there are two criteria we have to look for, the clinical criteria and the radiological criteria. You should not preferably do a selective thoracic fusion in a child who is immature. Again, with the growth, the adding on and problems are more. In case, we usually try to wait for riser 2 to do a surgery in a patient with AIS. The minimum criteria we prefer is the triradiate cartilage is at least fused. That means about 80% of the peak growth spurt has happened. There are certain situations, an immature child with a higher degree of curve, we may have to operate earlier. That is the so-called tween age. In that situation, you have to be very careful when you are opting for a selective thoracic fusion. If the child is very active, plays Bharatanatyam, want to play again, is very active in sports, it's better to discuss with the child and the family, and if possible, try to do a selective thoracic fusion. Be always careful of subtle signs of ligamentous laxity. If this sign is positive, that means the thumb sign or the wrist sign is positive, then you have to be very careful. These children have got ligamentous laxity, may not be ideal candidates to do a selective thoracic fusion. There are a lot of outliers. Your expertise, the willingness of the patient to undergo a second surgery if necessary, but these are the guidelines to be followed in majority of the patients. Coming to the clinical criteria, you look at the prominence of the rib hump when corresponding to the lumbar hump. You use a goniometer, and the ratio, if is at least 1.2, that is thoracic is greater than the lumbar, then you may think of a selective thoracic fusion. We all know the radiological criteria put forward by Lenke et al. The ratio of the main thoracic to thoracolumbar curve, if it's greater than 1.2, you can do a selective thoracic fusion. It is in terms of the Cobb angle, apical vertebral translation, and apical vertebral rotation. What does it all imply? That the thoracolumbar curve is more flexible than the main thoracic curve. And you should always look at the lateral X-ray, that there is no kyphosis of the thoracolumbar junction of greater than 10 degrees. This is how you determine the apical vertebral translation. You draw a vertical line from C7 and measure the distance from that point to the apical vertebra. That is thoracic apical vertebral translation. Whereas when you measure lumbar, you draw the CSVL, and the distance of the apex from it is the lumbar apical vertebral translation. Therefore, when not to do, as I mentioned, basically what when you have to do, when not to do. Skeletal immaturity, number one. When there is a significant loin hump. And in the larger lumbar curve, even though it is not structural, if you've got a lumbar curve which is 45 degrees, which is significantly rotated, they are not ideal candidates to do a selective thoracic fusion. I would suggest that somebody is doing a surgery in the beginning of their career, you are not exactly certain what to do, go for non-selective, because in the beginning of your career, what is important is to have a good outcome rather than be worried about doing a selective versus a non-selective fusion. And these are some of the situations where it's a big thoracolumbar curve. It's better to go down to the stable vertebra and give a good results. How do you choose the LIV? There are two aspects to the fixation. How do you choose the UIE? How do you choose the LIV? We know that even though it has been given in this article by Trobish, the persons who first popularized this is Suk. It is called the Suk's rule. If you have the right shoulder up in the main thoracic curve, you go to T4. If you got the left shoulder up, you go to T2. If both the shoulders are at the level, go to 3-3. It's a simple rule. There are exceptions. Therefore, but this is a simple rule to follow when somebody is starting their beginning of their career. Okay, this is a simple rule for choosing the UIE in case of a thoracic curve. Then the difficult part is choosing the LIV. You've got two options when you do a selective thoracic fusion. You can choose the end vertebra of the thoracic curve. Okay, therefore here T4 to T12 is the main curve. You choose the end vertebra of the thoracic curve. Okay, that is one option. But however, especially in the type C curve, studies have shown that there is a higher chances of adding on, higher chances of problems when you go to the end vertebra to choose as a LIV. The other option, which has been accepted well in the literature, the chance of outcome having a better outcome is good, is usually choosing the L1 are the stable vertebrae. The stable vertebra is drawn by drawing a line midpoint of the sacrum and draw vertically upwards, perpendicular to it. The vertebra that is bisected, you can go to the last touched vertebra. You can use this situation. The stable vertebra is always the better one to choose to have least problems. It is now well accepted in the literature. Whenever you are doing a selective thoracic fusion in a classical, this is not a classical case. This is basically a type 1A or 1B curve. But whenever you have a type 1C curve, the curve is crossing across the midline. It's always safer to use a stable vertebra so that the complications are relatively lesser. As I mentioned, there are many different ways to determine the LIV, but as I mentioned here, majority of the studies, stable and neutral vertebra are what is used, whereas stable vertebra is preferred by majority of them. Okay, and it is now well accepted. Either you have to choose the stable vertebra within one level of the stable vertebra. If you do an anterior surgery, you can go end to end. But however, doing a posterior surgery, it always boils down to the stable vertebra. And this is what Bett's criteria also is involved. I'll give you an example. See this curve? The end vertebra is about T11, but neutral vertebra is T12, and the stable vertebra here is L1. Therefore, it would be safe for you to use the stable vertebra. Basically, what does the stable vertebra means? The vertebra which is in line with the sacrum. Therefore, your construct will come in line with the L1 vertebra, and therefore the whole construct will be in line with the sacrum. Okay, that's all it's about. Our primary aim is to make the head centered over the pelvis. Therefore, the end vertebra of the construct has to be in line with the sacrum. That's what we are trying to do. That is what the overall principle of surgical management of scoliosis is about. Be always careful to look at the sagittally stable vertebra, also to decide the end vertebra in this particular case. Usually, the stable vertebra in the coronal view will also be a stable vertebra in the sagittal view. If not, the chance of DJK or the distal junctional kyphosis will be more. Once you have selected your upper end vertebra in a usual curve of a right thoracic curve, it usually will be T4 for me, and the lower level usually will be L1 for me. Therefore, once you have chosen this, you've got three types of correction you can do. I mean, three questions that comes to the mind. Whether to go for partial or full correction of the thoracic curve, whether to put all pedicles at all level or selective pedicle screws, whether to do a horizontalization of the lower instrumental vertebra or give a mild residual tilt of the LIV. That's the thought that comes to your mind. There are various correction manuals. For me, the convex rod first cantilever bending is what I would prefer, number one. I use lesser number of screws so that I do a lesser degree of correction. And in a type C modifier, always leave the last vertebra a bit degree of tilted. That means you are doing an intentional undul correction, incomplete correction of the thoracic curve, and residual tilt of the thoracic end vertebra. That's what I would prefer to do. It's basically because I would prefer to come to the stable vertebra. As I shown in this figure earlier, when you are coming into the L1, which is the stable vertebra here, that means you are already into the lumbar curve. If your correction ends from end vertebra to end vertebra, you can go for maximum correction because it allows the compensation to happen along the whole of the curve. But if you are going to the stable vertebra, which is already into the lumbar curve, it is always safer to do an under correction rather than doing a maximum degree of correction, number one. Number two, is also important to leave some degree of residual tilt of the L1 vertebra. And that's what I would prefer. In A and B modifier, you can horizontalize the lower end vertebra. However, in a C modifier, leave the under correction, you give some degree of tilt. Therefore, there is a smooth transition between these two. You see, this is an example for the textbook. I mean, from the book chapter, a old technique where they use a modified CD instrumentation. You see how here it is allowed to rotate so that it becomes harmonious with the lumbar curve. Okay. And you can see the amount of correction which happens whenever the curve is very flexible. Most of the time when you read the literature, in the Western world, most of them would have preferred to operate on a curve which is relatively around 45 to 55 degrees. The lumbar curve is flexible. Therefore, the amount of correction what they achieve becomes significantly more. As I mentioned, since I went to the stable vertebra, always leave some degree of tilt at the lower part of the vertebra. I don't try to get horizontal. It is completely like this so that it allows some degree of around the curve of the lumbar curve. Okay. You can have decompensation, but fortunately, most of them tends to be correct over a period of time because it is a dynamic. The unfused lumbar curve continues to improve over a period of time. But there is a changing opinion. Now, currently, if you read the Western literature, they all use all pedicle construct, put pedicles through at all level, go for maximum correction, and they feel that the results is better. But in my hands, I prefer to undercorrect, go to the stable vertebra, use less number of screws, cantilever correction using the convex rod. Okay, and these corrections are relatively maintained over a period of time as shown in the literature. The correction is not only in the distal curve, but also the proximal thoracic curve also undergoes correction in a curve that is relatively very flexible, as you can see in this particular example. As I can show you, the thoracic curve correction in the literature varies because the method of correction what people have used is different, both in the lumbar and thoracic curve. Still, complications like this can happen, but usually the lumbar curves modifies it and it corrects spontaneously over a period of time. So see the amount of correction that happens over a period of time as the patients mature, and over a period of time there is a body straightening response which tries to compensate for the tilt. And these results have been shown over a period of 37 years. This is the latest, one of the articles published in 2018 by Leinstein et al. Okay, this is the example from their series. I mean, which have been, I'm not going to speak much about this. The correction, majority of the literature has shown that the spinal balance and correction of the lumbar curve remains stable for over 20 years. About 36% of thoracic correction matched by 34% of lumbar correction. And that has been shown. Anterior gives you better results. As I mentioned, there are certain problems with selective thoracic fusion. Decrease in the amount of deformity correction, risk of adding on, and risk of decompensation. I will stop at this point by concluding that selective thoracic fusion should be the treatment of choice whenever you're doing a type 1 curve. Either A and B is 100%, C majority of the time, unless the curve is significantly rotated or greater than 45 degrees. Deformity progression is relatively rare, is less than 10% if the criteria is properly maintained. I mean, is less than 1%. You have to select your LIV and UIV very carefully. Complications happen, but however, less than 1% of the patient needs a revision surgery. Even though there is an adding on, most of the time it's an acceptable one. You need not do a revision surgery. Therefore, I would suggest that you should always think of selective thoracic fusion, but it should not be the choice for your first few cases. Your first few cases should always be looking at giving a good results to the patient. Thank you.
Fantastic talk, Ajay. Superb. It just covered everything, but it has also raised lots of questions in everyone's head. So we can just open this up for a 10-15 minute Q&A session before we move to the cases. Does that work for you?
Yep, sure.
So I think, since I'm on face, I'm going to ask the first question. I think, so what comes to mind is that now we have gone away from straightening a scoliosis to balancing a scoliosis, which means that if you leave a lumbar curve after your surgery is done, what is the incidence of back pain? Because we always, consider operating a type 5 Lenke or a lumbar curve to prevent back pain. And here you're leaving a residual back pain. I mean, a residual curve in the lumbar spine. So is there any study in your reading that talks about residual back pain or lumbar functionality after STF?
See, the thing we have to understand is the fact that every patient with a scoliosis after a period of time, 20 to 30 years, will have some degree of back pain. And majority of the published literature, what you see, were done in an era around 40 to 50 years ago, where people were much more tolerant and acceptable. Okay, that's number one. Number two is the fact that we are bringing the lumbar curve to less than about 20 to 25 degrees. And majority of these patients with a lumbar curve of 25 degrees, we do not advise surgery. We advise surgery for a lumbar curve when it crosses about 40 to 50 degrees or 40 degrees or up to 50 degrees. Therefore, when you're doing a selective thoracic fusion, you are correcting the lumbar curve to about 15 to 20 degrees. And that is an acceptable range. Will they get back pain in the future? Definitely yes. And even in a conservatively treated lumbar curve of 20 to 25 degrees, the only difference between a patient who get a back pain or do not get a back pain is the physical activity and exercises they do. A person who does physical exercises regularly will have a less incidence of back pain compared to a patient who doesn't do any physical activity, who puts on weight, inactive, poor muscle structure, they develop a lot of back pain.
I think that's a logical answer. I'm still going to push my agenda and say the thought that comes to mind is we take the risk and do a short fusion, and we still are talking about residual back pain, and then we don't go to L3 because we don't want residual back pain.
Agreed.
So that's a bit unclear.
But Abhay, my point is the fact that the child is only 12 years of age, and you are giving the child 20 to 30 years of good mobile life. Therefore, it's okay. Because we have to tell them that the child may need an extension later in life. But we are giving a child, if she is playing Bharatanatyam, she wants to play sports, that active life for the 15 to 20 years. That's what we are gaining over a period of time. And also science is advancing. We don't know what they're going to get. We are giving them a time of 15 to 20 years.
Makes sense. Amit is asking how many levels should be spared to, like in your reading, is it like stopping at L3 is okay, or you need to stop at L2? Like if you want to get less back pain, at the end of a surgery, how many discs should be spared?
There is no major differences when you stop between L3, L2 and L1. Okay, because why in a selective thoracic fusion, why you would prefer L1 is because it's a stable vertebra. Otherwise, you're getting into a curve which is tilted away from the midline. However, whenever it's possible, you can go as high as possible. L3 and L2 is preferable. Never go to L5, L4 when it's necessary.
Right. I hope, Amit, that answers your question. Amit is asking one more question. Amit is Dr. Amit Jhala. He's asking, how many patients actually do you have come across with disc prolapse and back pain in your practice? Because now you've been out there for 30 years.
Yeah, we have follow-up of around 15, 20 years, a good follow-up of a good number of patients. As I shown that we did 100%, 100 people analysis about 10 years follow-up of MRI. I have seen probably 2 or 3 patients with disc prolapse below the level of lesion, around 10 to 15 years follow-up. But we didn't have to do any intervention, treated conservatively, they are fine. Do we get patients with back pain? Definitely yes.
But I mean, it doesn't beat the odds of back pain in patients without a scoliosis, isn't it? Like,
yes, agreed.
That's what. So
agreed.
Yeah.
But I agree to that fact. But we have to give the best to whatever the patient is possible, not compromising the correction or the balance.
Yeah.
The primary aim is to have a good correction of the sagittal and the coronal balance. But if it's possible to save the levels, we should try to do that.
Yeah. I mean, as I hear you, I think resonate with your thought that if your skill sets are high, if you're an experienced scoliosis surgeon, you should do this high stake operation and otherwise settle for second best, but not give the patient a poorer result.
No, it's not a second best. As I mentioned that if you are starting very early in your career, I mean, you always should aim for a perfect result. Don't go for non-selective fusion. I tell all my fellows, don't be thinking too much when you're doing your first 10 to 15 curves or still you are established. If Abhay says, okay, this curve is acceptable, the patient will agree. But a guy who is starting today, the family sees a lumbar curve which is bent, they will be disappointed.
Yeah. Lots to talk. Dr. Arjun Dhawale has a question that, is there any cutoff value for the lumbar curve in your own opinion? And is there a
Yeah.
cutoff about lumbar rotation that you worry about?
For me, the cutoff value of a lumbar curve is about 40 degrees. I would take into consideration the degree of rotation, maybe grade 3 to 4.
Yeah, so more rotation you would worry about.
More rotation, even though it's flexible, I wouldn't hesitate to go. I wouldn't hesitate to go to L4. I'm not a guy who prefers to do selective thoracic fusion. If you see in the X-rays, whatever X-ray has shown is basically 2A, is not 1A, B, not the classical 1C. I would, if there is a doubt, I go to L3 or L4.
But don't you think, Ajay, there's an inherent flaw? Because when we call these curves or judge lumbar flexibility, we are totally relying on bending X-rays, and we know that there's a huge flaw in the procedure of flexion. I mean, of bending X-rays in the lumbar spine. They may not actually represent how flexible that curve is.
For me, I take two. Most of the time, I try to rely on traction X-rays. Okay, especially when the curve becomes bigger. If the curve is 70 degrees or 80 degrees, I never try to do a selective fusion. Selective fusion in my thought process comes when the curve is between 45 to 60 degrees. When the curve is 80 degrees or more, I would definitely go to a stable vertebra, which most of the time will be L3. Sometimes could be L4, but most of the time will be L3 or L2. I never think of selective thoracic fusion. I didn't mention in the talk, but I would like to highlight to whoever listens, don't try to do a selective fusion in a curve which is about 75 or 80 degrees or more. Your aim should be to the stable vertebra because you are using a lot of force to correct it. That's number one. And therefore, when you're doing a selective thoracic fusion, you can think of only in curves which are flexible, which is in the range of 45 to 60 degrees. Then only the flexibility, even though you're using a side bending, there is a flaw. But if you are able to get a better degree of flexibility, it could be acceptable.
Also, there are two other controversial points in your talk, which I'm comparing, or I remember the talk given by Peter Newton on a similar forum on STF, who's one of the proponents of STF. He said that you have to aggressively derotate your base vertebra, your LIV, last instrumented vertebra, while you say that you want to leave it slightly undercorrected. And the second is he said that you have to create a good sagittal profile, which means a good thoracic kyphosis. You have to leave the patient with a good thoracic kyphosis for the lumbar curve not to fail. And you say that you want to do a convex cantilever maneuver, which is a hypokyphotic maneuver compared to a rod derotation maneuver. So what is your stance on?
I don't have answer for that. I have tried doing complete correction with all pedicle screws and I burned my fingers. That's the reason I've seen adding on, I've been seeing decompensation. And that's why I told you already, if you look at the current literature from the West, they advise all pedicle screw construct. They go from end vertebra to end vertebra and they are aggressively correcting. They say you have to get a better kyphosis correction, but I don't know. In my hands, I go to the stable vertebra, do moderate corrections, and I'm quite happy with this. When I used to do aggressive correction, I had few add-ons and did a revision once also.
And when you mean stable, you mean the last significantly touched vertebra. Is that the one that you
it could be stable or the last significantly touched, depending upon where it is.
Right.
Usually I don't prefer to stop at T12 because again, it comes under the thoracolumbar in the sagittal plane. I prefer to go to L1.
Right.
And most of the C curve, L1 becomes the stable vertebra automatically.
Got it. And what is your experience about, shoulder imbalance kind of coming in play to compensate for a decompensation or an add-on that's happening at the bottom? Have you seen that happening?
It happens, but what happens is that when the shoulder imbalance corrects, the last vertebra further tilt. The shoulder imbalance, when it gets corrected, it has to correct somewhere.
Yeah.
The correction, when you take the X-ray, you realize that the L1 vertebra starts to tilt in a different direction.
Right.
Inevitably, whatever you do, you will have around 10 to 15% of the child with some shoulder imbalance. And you can't help it. Whatever correction, whatever maneuver, whatever planning you do, I always find 5 to 10% of our patients having some shoulder imbalance, which is reasonably quite acceptable. But some people will have medial shoulder imbalance, which doesn't look good. I don't know what's the answer.
And then there's a question, of course, Dr. Arjun and Dr. Amit both want to know what are your criteria for STF, but I think you mentioned them quite clearly. But does your criteria change with age? Like, is there an age cutoff that you would, bend those criteria, or just go by RISER 2 or plus or minus?
I would go for post-menarchal, riser 1 or 2. I mean, riser 2 is probably the safest best. If they are younger, like no, the youngest I have operated even a 9-year-old child when the curve was about 80 degrees, what's so-called tweeners. But you cannot, I never look for selective fusion in this age group in case I need to do a surgery.
Got it. And again, Dr. Dhawale wants to know, do you use poly or uniaxial screws at the LIV?
Okay. I would like to, I always use polyaxial screws in a thoracic vertebra. When I am doing a lumbar curve, the lower lumbar vertebra, if it's rotated, I try to use lower 2-3 screws. In the lumbar curve, I use uniaxial so that I can do the correction. But I am not particular about using in a thoracic curve uniaxial screws.
Got it. And so, by and large, what you're trying to say is that undercorrect is your formula rather than, full correct.
I'm not saying it's a perfect formula, but it works in hand with me. When I try to put complete better correction, I always landed with problems. I don't know. Is it
off the top of your head, how many of your STFs have you needed to go back and revise? Like
only one?
One. No, even for me, it's only one. Anyone else in the faculty? Appaji, how many STFs have you needed to revise? I think we can say that all of us have done, quite a few dozens of STFs in our career, and one in that many is not that many. Arjun says 3.
No, Arjun, sometimes they are not acceptable, but the spine is balanced. Radiologically, it doesn't look good, but the spine looks balanced. It depends on how you deal with the patient.
And Arjun deals with a uniquely young group of patients. So I think if he's got 3, which means even I have more than, because I'm a part of that team. So I think it's the younger group that always fails on you. Appaji, what about you? What's been your experience?
Only one case where we had stopped at C11 instead of C. I mean, what Ajay said, I agree. I go to L1 or L2, doesn't matter in selective thoracic. Only one case where we were very distinct and stopped at T11, and we had to revise it to L1.
And Appaji, what has been your team experience of doing an anterior STF, like a selective thoracic, but through an anterior approach?
We've linked 1C. We have had good results. One of the kyphotic thoracic, we had a failure. So out of 14 or 15, which we did fusions, not non-fusion. Fusion cases, one was a failure. Rest all had very good results. And we used to get almost like, you would have seen most of the X-rays, we will get less than 5 degrees correction, and we stop at T12 in anterior. We never go to L1.
And what does the entire faculty feel that when you're doing an STF, is osteotomies and, thoracoplasties should not be done when you're planning an STF, which should be just a clean surgical maneuver? Ajay?
Yeah, as I told you, I do not prefer to do a selective thoracic fusion in a curve which is 80 degrees. Therefore, the question of doing a corrective osteotomies, costectomy never comes in these curves. You see, most of these patients are about 45 to 60 degrees, very flexible curves. Therefore, the need to do a Ponti osteotomy itself is not there.
Got it. Amit or Arjun, or Appaji, any thoughts on that, or Hriday?
Also, yeah, STFs where we have done pure STFs, as I said, not on those who have like huge curves. Most of them we have gone to L2. If we are stopping at T12, most of them are less than 60, and we were able to do it without thoracoplasty.
Right. And then Ajay, finally, why do you choose the convex cantilever maneuver rather than the rod derotation maneuver?
Again, lessons learned over the year. Rod derotation maneuver or a concave rod, you end up correcting. You cannot, I don't find, moment you start doing it in these flexible curves, the deformity corrects in the thoracic curve. And therefore, people have said you just do only 90-degree rotation. I find it's difficult for me to control that amount of correction, whereas it's much easier when you do a cantilever technique.
And how do you plan that
Amit, you
angle?
got anything to add?
I mean, how do you plan the angle? Like, if it's
I
a
don't
40,
try to
40.
plan the angle too much. I just do a cantilever and then keep the lower end vertebra mildly tilted. And therefore, usually it's quite okay. I don't overthink too much. A minor degree of correction, I always find they look quite balanced. They're okay.
I mean,
When I started doing more and more correction, always they come up end will be like suddenly it tilts down.
yeah. Because when you do a convex rod, it's normally a straight rod that you push in. So here you push in a curved rod, I'm guessing. So do you angle like that curve measurement is there a rough thing? Can you go to 20 degrees or like is there some? I mean, that's the question that any first timer is going to ask you that you're
No,
asking.
my point is that I just change bend it in the kyphosis, and the upper part of the rod is slightly bent more so that it sits on the T4, T5 screws quite well. You lock it and then you push it down so that you are correcting it and bring it down.
But you don't leave a bend in the coronal plane. You let the rod take its own
No,
shape.
yes. But still
Yeah,
you need some degree of, yes,
Yeah.
Appaji.
yeah, I'll add to that. Yeah, like what Sir said, we also use most often what I do is in the apical three, I just put those reducers, have this screw rod fixed from the top and cantilever it to the bottom, and then slowly reduce it. The middle one just comes back to position if they are like flexible, selective thoracic.
We'll ask,
Unless otherwise you had a bad screw where you can, there can be a screw pull out. Otherwise, you can easily do it.
And
Amit, your
Appaji,
technique.
100% screws or much less than 100% screws for STF in
No,
your
no, no, 100% screws.
So what,
It's always
80%,
selective screws.
70%?
It's always selective screws.
Okay. Okay, great. Anything else, Ajay? You want to say something?
I think we can ask Amit and Arjun their technique of selective
Yeah.
thoracic fusion, how they do the correction.
Both of them are not able to speak. I think they are in some
Okay.
situations. If you are to say
Okay,
something,
no,
unmuted.
Abhay, what's your technique?
I'm that go for maximum type guy. Like I normally go for maximum correction. And I believe that like this is a belief. I guess I don't have enough numbers to back me up, but I can tell you that I've had to revise only one adult means an adolescent grown up patient to this thing. So I go for the full hog. And I feel that the lack of lumbar correctability is more because of poor X-ray techniques and rib causal impingement. So I normally go the whole hog. I give solid kyphosis to the thoracic spine and I derotate aggressively the lower vertebrae of my construct. But overall, I try to do less STFs and I try to go like
Yeah,
I
I
believe
agree.
that going to L3, you're going to have an equally successful result. I've had girls who have fused to L3 doing break dance and doing marathon running. So yeah.
And there's one more reason when I do selective is you've got a curve in the lumbar one, which is already going into L5. L5 also, you feel that even if you stop at L4, you may not get a good results. I explain to them and say, I'm going to stop at L1, but this curve is going to partially correct. And then maybe when she's 30, 35, when the family life, delivery, everything is over, we can consider one more.
Yeah, that's a good
Hopefully
point.
by that time, I might have retired.
It's a good point. It's a good point. Super. So I think it's been a very healthy discussion. Should we move on to cases or any other
Yes.
questions, burning questions? I'll encourage the faculty to take full part when Hriday starts the case presentation. Hriday, are you if you're set?
Yes, sir.
Abhay,
Please.
kindly excuse me. I'm just getting into the airport, so I'll just log out.
Okay. Thank you.
Have
Thank
a
you.
nice time, nice flight. Enjoy your time in Pune.
Not Pune, sir. I'm going to Colombo.
Oh,
Okay.
getting more
Okay.
patients.
Pune
Yeah.
of
Scoliosis survey.
Okay, doke. Let's get on. Thank you, Appaji. Let's get on. Hriday, can you share your screen and present your first case?
Okay. The screen is visible, right?
Yes.
Yes.
So, yeah. So, this is a case of a 14-year-old female post-menarchal with full maturity. She had a deformity in the back which worsened over 2 years with normal MRI and no neurological complaints. And these are her clinical pictures when she came to me. So, here we can see that the right shoulder is a little higher than the left one, and right-sided rib hump. She also has an S-shaped deformity which can be seen here. So,
But looking at it, Hriday, the
yes,
thing what strikes is a curve which is probably 50 to 60
60
degrees
degrees.
of
Yes.
curve. The lumbar curve is not structural, and therefore this would be an clinically ideal case to do a selective thoracic fusion. Clinically,
Okay.
when
So,
you have a radiological.
so then we got the X-rays done, and here these are the end vertebrae. That's T4 and T11. So we can consider T11 or T12 that can be end vertebrae, and the main thoracic curve is 55 degrees. That's the thoracolumbar lumbar curve, which is 35 degrees. And typically, as an AIS, there is hypokyphosis, which we see. So, to classify based on lanky bending curves, X-rays were done. Again, on bending X-rays, the main thoracic curve changed from 66 to 45. So, it's a structural curve. The lumbar curve almost straightened up, as you said, clinically. So, it's almost 20 degrees and it's a non-structural curve. So, we classified it as a lanky type 1 curve.
Can I just butt in here, Hriday? I'm just slightly worried about the proximal thoracic curve. If you see the apex of the main thoracic, it's a bit low-hanging apex.
Yeah.
The shoulder height difference is not commensurate with the magnitude. It's like a 66-degree curve, but the shoulder heights are reasonably level. So I think the proximal thoracic curve has to be thought about, and this could be considered, or you may want to consider this a double thoracic curve, then which then becomes a controversy for STF. I'm just throwing in a,
Yeah.
throwing
No,
in.
you can do a selective thoracic fusion, but you can go up to T2 and choose it.
But still, the patient has a thoracic and lumbar curves, which are maybe the lumbar curve is non-significant. So because of that, also the shoulder balance might compensate because the shoulder difference is not very huge, as we can see here.
Like
But
if you see,
Hriday, have you measured the upper thoracic? I agree with Abhay.
Yes, no, the upper thoracic curve was not measured. So I think
You should measure because sometimes post correction you may get a shoulder imbalance in such cases. If you miss
I
out on
suspect
that.
that because even the bending films, if you see, the proximal thoracic just sitting snobbishly.
yeah.
It doesn't want to budge. Of course, these bending films don't actually make a difference to the proximal thoracic. You need massive neck bending films. But you got to think about this for sure. Like I would worry when I correct my thoracic curve, the other shoulder is going to go up. Ajay, you don't think so?
Yeah, the message here is one is we should try to get a whole spine X-rays. I mean, we have to find a center which will be able to take the whole spine X-ray. I mean, that's very, very important for us to plan. And it's the second message is always measure all the curve. You will never go wrong. The common mistake when we start early in your career is we fall for the obvious, measure only the thoracic curve. Our fellows still do it. A lot of time they measure only the main curve. Make it a habit that we measure all the curves so that we do not make the mistake of missing. Because moment you see it's 30 degrees, then your mind will start thinking differently than what you are thinking now.
Dr. Arjun has brought out another point. How will you classify this as per, again, Peter Newton's 1 AR versus 1 AL based on the L4 tilt? Hriday, if it's a type 1.
It's the type 1 and the tilt is on the right and it's also correcting. So it will be a 1 AR, but it's a flexible lumbar.
Flexible, yeah.
1 AR means that the whole thing will be rotated to the right side. The end vertebra usually becomes L3 when you are doing the instrumentation. It doesn't look like 1 AR, it looks like 1 AL only. Because the second curve is going away. It's like a yes.
Arjun, what do you think? 1 AR or 1 AL?
I'll put the these are bending films, so straighter films for the classification.
But if you see here, it's definitely 1AL. This is completely rotated away.
Yeah, it's gone to the
1AR,
It
it
is
will
one
come.
AL, one
Yeah,
AL.
L.
those
So
are
it's a
bending.
favorable tilt of the L4. Fine, go ahead.
So the hospital does not have full X-ray facility, so we would just be able to find the CSVL based on the pelvis ribs that we could see here. So it is more like a type C lanky because the apical lumbar vertebra is completely shifted from the CSVL. So we classified this as lanky type 1C.
Yeah, that's fine.
So now again coming to the management options that we have. So in the faculty, how would you plan? It will be a STF or a non-selective fusion. So first to Ajoy sir.
With the information what we have, I think I would go for a selective thoracic fusion. I would still look, for me, I'm not sure whether the vertical line, you're down the stable vertebral line is coming up to T12. I still feel it looks like it's coming for L1. I'm not exactly certain. The midpoint seems to be away. For me, I would still prefer to use a L1 rather than T12 in this case.
Abhay sir.
So I think if I think about the criteria mentioned by Dr. Ajay, the criteria in favor of STF are this is an older child. There's no significant flank crease in the lumbar, like the lumbar curve is not clinically very apparent. And the lumbar curve is very flexible on the X-rays. The thoracic curve has much more qualities or much more quantities than the lumbar curve. So everything fits in favor of a selective thoracic fusion. What worries me is the proximal thoracic curve. So Dr. Arjun on his text has written he'll go from T3 to L1. I tend to agree. I might even go to T2 to L1. And I won't stop at T12. I'll choose a selective thoracic fusion, and I will go for broke. I will not leave. I'll go for maximum correction of the thoracic spine because I feel the lumbar curve is really flexible and we can do a good job. The slight concern is how am I going to address that proximal thoracic curve because I'm not going to be able to derotate it. I may be able to capture it in my fixation, but to correct the proximal thoracic curve is not so easy. So the slight concern after all this positive is that after all everything is done, the left shoulder may still sneak slightly higher. That's my worry. What about Amit? What do you feel?
Yeah, so I absolutely agree that this is a curve where you can go for a selective thoracic fusion. I would definitely go up to T2, as you say that from it's my feeling that it is also a structural one. If we really measure in both the planes. One more point I would always like everyone to take clinical point is that if the patient has got uh, a sports activity or a dancer, then definitely a selective thoracic fusion is much as a clinical criteria I would go for it. But here it is T2 to L1. That is what I would do because it's absolutely flexible on the bending films.
So then levels, this is already we have discussed. So what will you counsel the parents, so Jhala sir, for the lumbar curve that
For two things, for the shoulder, I always counsel for the shoulder. Even if everything is there, sometimes there is a shoulder balance, which is sometimes a problem. Even if you have done everything, shoulder is one thing. And definitely for the whenever you're doing STF, you have to counsel that we are doing a little bit shorter fusion. And I will definitely, you always measure the curve every 1.5 months and follow up. So on follow up, if you feel that it is instead of compensating, it is decompensated, I'll extend the fusion below.
So
I would say
Abhay
that
sir, anything? Yes.
yes, Hriday. I would say that you have to be extremely careful of a very flexible curve. You've got a curve of 75 degrees, is always straightforward. It's easy for you to choose the upper end vertebra, lower end vertebra, and go and do the correction. When you have a curve which is flexible, you have to be extremely careful. Therefore, people might think a 55-degree curve is simple to operate, but if your planning is wrong, you will end up with decompensation and a poor results. As against a 70-degree curve, the results are usually much more predictable.
But having said that, if you go up to L3, I don't mind in even this case as a novice.
I agree.
So surgical steps is what we already discussed in the presentation of with Dr. Ajoy sir. So yes, again, L1 or no L1. So if we plan an STF,
No, I think Amit was busy that time. Amit, what will be your correction maneuver when you do a selective thoracic fusion?
So if it is a hypolordotic with a selective, I will go for concave first. Definitely, it's a hypo. It's from that. But cantilevering will be my main. I will do a lot of kyphosis and then try to pull the apex with full on at least on the concave side all the fixations, and then with the kyphosis and cantilevering, that is the first thing rather than rod rotation. And the convex also I'll do a hypo and try to push the apex towards the concave side. So both the things, both the things, it is cantilevering as the main force for me.
Okay. So going to L1 or no L1 if we plan a STF. So I think it was unanimously everybody planned that going to L1 is a better option than going to D12.
Hriday, if you are not able to get into the pelvis, you choose the midpoint of the L5, assuming that L5 is over the pelvis. And therefore, if you draw a line from there, L1 becomes the stable vertebra. Okay?
Yes. And the last question is derotating the last instrumental vertebra. So in practice, do you derotate the last instrumental vertebra whenever you do a selective thoracic fusion?
So in my book, if the lumbar curve is very snobbish, I try to not work very hard on the thoracic curve. In a curve like this, I would work hard and want to over derotate the last one or two LIVs, means the lowest one or two instrumented levels. So the answer is it would depend on the flexibility of the lumbar curve.
That's what is advised, but I somehow tried avoid doing that.
So this is what I did for T4 to L1, a selective thoracic fusion. Little hypocorrection, then there was still residual lumbar curve which was present. We tried to derotate the L1 as much as we could during the correction. So these are follow-up X-rays. It's the kid is almost 8 months post-op. So the lumbar curve is already correcting, as we can see in the X-rays. Now,
What is the correction maneuver, Hriday?
Sir, so we did the concave rotation and then the convex cantilever when we did the correction here.
The only thing is that slightly hypokyphotic rod. I would have been much better if the lateral profile or sagittal profile would be much better, because you see there is some below the LIV, there is some kyphosis which is arising, which I don't like. I don't know why.
No, that's absolutely true. And even that last screw on the convex side is not sitting in well, and you would rather have shaped the rod. Like,
so that came out when we were trying to derotate. Everything was fixed. We tried to derotate, and that time it just shifted the screw when we tried to derotate the last whatever. So I think using a monoaxial screw might be a better idea than polyaxial during derotation.
No. Don't try to use a lot of force on the distal end vertebra. I mean, unless you are very sure of your construct. Therefore, there are a few things you have to be extremely careful when you're doing scoliosis. When your distal screw is relatively weaker, the chances of problems are very high. It can happen over a period of 1 to 2 years also. Therefore, your distal screw hold is very, very important.
Arjun has a very good point that you should avoid derotation if you're doing the proximal thoracic curve also. What do you guys think about that? Like if you're including the proximal thoracic curve in your fixation, a derotation could spin it off in the...
I usually do not derotate much.
Dr. Menon has done a lot of work on this, and how to do, like he sometimes does a short proximal thoracic curve correction on the convex side, then uses the long rod and the convex, making a double thoracic into a single thoracic, and then doing a correction maneuver on the other side. It seems a lot of work according to me, but I've seen him do that. But I think what Arjun said is makes sense, that if you can just capture the proximal thoracic and then use a convex cantilever, So you don't derotate. Otherwise, the proximal thoracic will rotate on the other side.
So I agree because nowadays, initially I was doing a lot of derotation, but my main maneuver has gone to cantilevering rather than a derotation. Initially, like CD, that is what we started. But now the main, because of the good instrumentation which are available, which were not before, we are able to capture the road and we are able to pull the apex back. So cantilever will solve all these problems.
Right.
And the other thing is that using too much of correction proximally also is very difficult. When you're putting a screw, especially when you're going through navigation, you find T2 is good, but T3, T4 screws are, especially T3 and T4 on the convex side, they are so small. If you try to manipulate it too much, it will just come off into the hand.
But I think the clinical result is excellent, no?
Yeah.
So we have this left shoulder thing that we have been discussing. So the left shoulder is a little higher as compared to pre-operative. We had the right shoulder up. So these are this was pre-op. This is almost 2 weeks post-op. This is 6 months.
I
This
don't think the
3
left
months.
shoulder, I think it's fine. The shoulders
She's
adjust.
standing. Yeah.
No, I think Rida, your pictures taken are not in the same position.
Yeah, the hand was like that, so that's
Yeah.
the difference. But the post-op, this is almost 3 weeks, and here everything looks balanced.
It's okay, acceptable, whatever it is.
The hum
Correction.
is also reduced on both the sides.
And she's happy, right? I
Yeah,
think
she's happy. She has no complaints, no back pain, at least for now.
it's a good result, I think.
So it's
So I think
about picking the bad apple instead of taking the entire bowl of the STF.
yeah, that's perfect. I think this was the ideal case, Hriday, to demonstrate everything that Dr. Ajoy Shetty's lecture actually mentioned. So we put it into practice. We can, if there are any other comments from the faculty or the other presenters, otherwise we'll quickly move to Sharvin's case because that's a slightly different case. Are we good?
Yeah, we're good.
Perfect. Sharvin, go ahead. You're muted.
Is the screen visible?
Yes.
So let's go straight to the case. It's a 14-year-old female who presents in the OPD with this particular problem. So how do we first assess deformities of importance? We see the shoulder level and the hump, and we get a rough idea of what type of curve it would be as we see the thoracic hump. So any comments from the faculty on what specifically we should be seeing that would take our mind off of AS, that we should not
She
be.
looks like a tiny 14, Sharvin. She doesn't look like 14. She looks like a 7 or 8 year old girl. And it looks like a, double major at least. They're like two, it's an S-shaped curve. There's a
Yeah.
significant loin crease also and, a rib hump also. So it looks like the lumbar curve is doing stuff there. The distal shoulder balance looks equal. Proximal shoulder balance on the right, right trapezius looks more full. So this curve, the thoracic curve possibly is extending it into the upper thoracic spine. It's like a slightly atypical variant of the Lenki variety. That's my clinical assessment. If anyone else has anything else to say.
Yeah, that's fine. A double major curve. Looks like both the curves are structural.
We'll move on to the X-rays. So these are the X-rays, the standing AP view, lateral view, and the bending films. We can see that the thoracic curve is 78.3 degrees and the lumbar is 54.6 and the proximal thoracic is 37.2. But the lumbar is pretty much flexible and goes down to just 1.2 degrees, and even the proximal thoracic becomes straight. And if the flexibility of the primary thoracic curve is also quite a few, it goes down to 41.8. So
And she's a reserve 4, right? She's a post-menarchal and reserve 4.
I think so, she looks like a reserve.
You can see are you easily able to flip this picture? Because this is spinning my head. The picture on your right, if you're able to easily spin
Yeah, I'll be able to do that.
Will help because we are not able to think correctly. Because
Numbers will
though
also depend.
we should go by the numbers, I think visual gratification is equally important. Visually to imagine the CSVL. She's post menarchal, I'm guessing.
Yes.
Yeah.
Yeah, so she's a reserve 4 then, because I could see the
So yeah.
MRI is normal.
There.
Thank you.
So we'll go in a step, but I think how would we classify this as a Lenki? We uh, looks like a 1C from like the major curve is structural. The proximal thoracic and the thoracolumbar are pretty flexible and they go down below 25. So it should be 1C if I don't know,
I
Ajay sir?
agree.
Yeah, by classification is 1C. But however, the curve is significantly more, 54 degrees.
Yeah.
The rotation is more. Clinically, there is a significant loin prominence. Even though it's flexible, I would treat it as structural and probably go down. Maybe it looks like L4 to me, or it
L4.
could be L3. I'll just.
So next is our instrumented level selection. So what would be the LIV for this case? Jhala sir.
The upper instrumented vertebra first.
Yeah, let's go with the upper instrument.
T3 for me. The upper instrumented would be T3 for me.
For me, it is D3.
Why D3?
One thing is that if you see CSVL, it is cutting at T3, and the other thing is that shoulder on the right side down. So I don't want to go much higher, and I don't want to go to T4. I think T3 should be ideal.
This is the principle of Harrington. When you go through the Harrington zones, the upper end is inside the Harrington zone. And that's why both Abhay and Amit are feeling that T3 would be a right one. For me, it will be
Simple
usually,
thumb rule of KV Menon is UEV plus 1. And if that's falling short of T2, then that's good enough. If it's going beyond T2, then it's not okay. Then you stop at UEV.
okay.
So we can agree
LIV
that
is the question, I think.
yes, UIV would be T3 for most of us.
Hriday, what's your LIV?
Why I think Arjun has told T4, and what about Ajay? For
I usually go to T4 most of the time when the right shoulder is up.
okay.
But I agree with you that T3 will make it easier for you to put the screw and get it in alignment. The T4 screw somehow will be very thin on the convex side.
Okay.
There are many ways to look at it. There are a lot of people will look at the chest cage in the top and they choose the midpoint of it. Either if T4 is the midpoint, they choose T4 or T3. As you said, the Harrington zone wise, you can go up to T3. That's also fine.
Okay.
Any inputs from Dr. Hriday? For the
Yes,
upper instrumented vertebra?
T3 would be because it is in the line of CSVL, and probably the planning for the entire surgery would be centralization of both the curves because it's a huge S-shaped curve. So we'll do a T3 to L4 because just fixing proximal thoracic curve will be a huge risk even if it's a 1C curve with such huge angles.
Right.
Abhay?
I'm slightly bold, except that I'll have to talk to her about a loin crease. If she's not so much worried about the loin crease, I probably will go much higher, like L2, like in the apex of the lumbar curve, literally, because I'm going to consider this as a flexible lumbar curve. L1 or L2 would be my LIV, unless the girl is a low risk taker, which means that she has no other, she's never ever going to come back for a redo. If I give her a 5% chance that she needs a redo, or if she's significantly concerned about the loin crease, because L4 is you're burning bridges according to me. So if it was going to be shorter than that, I would have been happier to take both curves in. But since my LIV is going to be L4, if I don't do a selective thoracic, I may be slightly bold and stop at L1 or L2.
it's T3 and
Ajay?
L2 for Abhay sir, L4 for Ajay sir.
I would probably go to L4. I'll discuss with them. Option is one, do a selective thoracic. I wouldn't stop at L2. Either, as per this, the stable vertebra is T12 or L4, depending upon what the patient wants.
Depending. And any takers for anterior correction for this, for the curves?
I have no personal experience on anterior
Yes.
STA, but I guess it works as well because it's a EV to EV fixation and great correction.
Ajay sir?
No, I have no experience with anterior. My anterior is basically for neurofibromatosis and things like that.
So just on the point, Dr. Arjun has replied why he chose T4 as the UEV, because he feels the same shoulder is higher, and there is the proximal thoracic is not structural. So he just goes by that flat rule. On the count of letting the lumbar spine off, like STF versus going to L4, he chooses L4 because he feels the lumbar spine is far too rotated. I kind of agree, but I still think on the left bending X-ray, the mobility of the lumbar spine is significant. Correctability of the lumbar spine is significant. And then I'm going to start looking at this like a C-type curve rather than an S-type curve. C not is a Lenke C. And then I would want to squeeze the LIV rather than choose STF versus like one or two curves. That's how I think. And hence that T12 rule, which as per Ajay's lecture, T12 should be the right LIV if you're doing an STF. Here I would think of it as, my correct LIV should have been maybe L4. Can I squeeze it to L3 and then L2 based on the bending films? And the rule that I apply is that if my current selected LIV is L4, on the bending film, can the L3 satisfy the criteria of a mobile disc of the lower end plate getting parallel to the intercrestal line and derotation? And then can L2 get those criteria? And in this case, even L1 is coming to that criteria. So I would choose L1 as the LIV.
So, according to Abhay, I use the same principle that you see bending is more or less corrected, the bending. So we can save a little level, but L2 would be at the apex of the lumbar with maximum rotation. And L4, if I want to save the level, instead of L4, I may take a chance at L3, check perioperatively that if I am able to make it parallel during surgery, the L3-4 disc. So you may go to L3. So that is what I would maybe L3.
I would agree with Amit in the sense that when you give patient is anesthetized, you position prone, and when you take a C-arm pitch shot, you find that L3 is in line with the lumbar lower level, then it could be a good one to choose.
What about the correction method, sir?
Again, I think the thoracic is a pretty flexible curve, so I would choose a derotation maneuver here, followed by a cantilever, followed by a DVR. So throw in everything and try to get maximum correction of the thoracic spine, because I'm committing to L1 and not going to L3. I want to really push my correction.
Same.
I would
I'll use
add-
the cobalt chromium rod and give maximum kyphosis to correct put the concave rod first, do the derotation if necessary, depending on the curve, derotation usually, and then cantilever the convex rod.
Any advice on the titanium versus cobalt chromium thing? Because early in the practice, we are scared of the strength of the cobalt chromium rods, of pulling our fixations out, especially when we are trying to aim and achieve a correction by pulling the apex, or by when we use the DVR system or the reduction systems.
The safe thing is to use the pushing rod as the COCR rod. So the convex rod, when you're using a convex cantilever maneuver, COCR rod is a no-brainer. But in the concave derotation maneuver, especially if your apical screws are dodgy, I would any day choose a titanium rod. So typically it's a convex COCR concave titanium.
The thing you have to take into consideration is, number one, the quality of the bone. If you find your screws are good, the hold is very good, you can use a cobalt chrome rod. Number two, the curves are more flexible, preferable to use a cobalt chrome rod. You've got a curve which is 90 degrees, very rigid. Don't try to use too much of a cobalt chrome rod, because when you're trying to correct, you may try to pull out is significantly more. I used to use cobalt chrome initially, but now in a severe curve, I would prefer to use a titanium rod.
Anybody would think of Pontes, or it will be without Pontes? This.
I don't think I'll need Pontes here, but yeah, I don't think I'll need. It's quite flexible.
You don't have to do a full Ponte. If you take off the facets, remove the bit of superficial layers of the ligamentum flavum, you get adequate degree of correction.
So only facetectomy, and that's what actually we do for putting the thoracic screws.
And also remove the interspinous part of the ligaments, and then, if necessary, remove the superficial part of the ligamentum flavum, but keep the ligamentum flavum intact.
Arjun wants a left-sided, that's a concave rod as the first rod, and he wants to do Pontes in the thoracic spine.
See how much the difference of technique between all. But the basic thing you have to understand is the fact that in a flexible curve, whatever the technique, either it's a cantilever, derotation, translation maneuver, basically the spine adopts to the rod because the spine is flexible. Your correction maneuvers comes into play when there is a spine is rigid. Here, the spine adapts to the rod. You have got a strong rod, the spine just comes towards the rod as long as it is flexible.
Also, Arjun has made an interesting point. If he's going to go to L4, and he says he'll compress the left-sided lumbar curve, so he gets a lordosis as well as a convex compression.
I think that is always that we do. Once we put a cantilever rod, then we compress the lumbar part and we distract the concave part of the thoracic. Once we catch the rod.
And we have discussed about the STF versus non-STF. I think Abhay sir went for STF, and the rest of the house is in favor of T3 to L4 or L3 kind of fusion. I'll just go to the post-op images. So non-selective thoracic fusion was done from T3 to L3.
Good, excellent. Looks nice, balanced well.
I like the sagittal profile. I think it's a nice sagittal profile.
Yeah.
So one of the things is when you use lesser screws, you get a better sagittal profile. Otherwise, you get a flat back. Any comments? The UIV seems to be T4, not T3. Correct?
Yeah.
4.
Yeah, 4.
So it's a 4 to 3 correction.
A very good correction, both on coronal and sagittal plane.
I mean, to be a devil's advocate, this would always come out good. If you did STF, would you do better? That would be the question to be asked, and we won't get an answer here.
So any particular thing you would counsel to the patient or the patient's parents if you are going for an STF in such a case with a large but yet flexible lumbar curve?
100%. Like I told you, the loin crease is one thing I want to talk to her about. Her need for flexibility and her potential for a second surgery, though I don't put that as a high risk because, of course, they're going to say, you decide. But I think these are the 3 things I say. So if it's a non-intelligent family from the interior rural areas, I would never think about STF. Nice. Any other comments?
I agree with you that, you need a base. There should be at least 2 screws on each side. You need in the top 2 screws at least. And between, depending on what you feel, you can go alternatively or put at the apical level. You have done it quite well and a good correction.
Ponte is done here?
No, sir, no Pontes is done.
So again, I want to be a devil's advocate. I really appreciate the way you've operated this, but I still want to put a few points out that with such less implants and with no Pontes, the correction is so good. I think this was still a good case for STF. It was a very, very flexible curve.
So in an STF, would the implant density be 100%?
I would do, yeah. I would do 100% implant density, full correction. Like here, you're getting a full correction even without a 100% implant density and no Pontes.
and maximum correction in the thoracic curve.
That's my formula, but I think Ajay differs on that, and it's each one's experience and how you
In a
work your-
flexible curve, you'll automatically get about 60-70% of the correction when you're doing it. Like it may look zero here in the coronal view, but if you are careful and measure, you will get some degree of curve there left.
Sure.
You have measured 20 degrees.
Great.
Any
Want
other
to
comments
move
from
to the next case? Sharvin, any points you want to still tell us?
No, sorry, it's been a great discussion. Thank you. So
Great,
this is
thank
a
you.
5-year follow-up of the same. And yeah, I just wanted to add, as
5-year
Ajay
follow-up.
said, that the shoulder balance is also improved at a 5-year, and even the lumbar spine, the non-structural lumbar curve is also, the pelvis is also balanced by itself over a period of time. So
Yes, that's nice. Can you just show the next slide, that 5-year follow-up?
this is the one, sir. The same on the right side.
Okay. Okay, fantastic.
Great.
Thank you, Sharvin.
Thank you so much.
Nishant, if you're ready, can we quickly go through your case? We are 10
Yes.
minutes to the hour. Should we have a fourth case, or should we? Let's see how quickly Nishant goes.
Nishant is very fast.
Yes. Go ahead, Nishant.
Yes, sir.
When you present, Nishant, let's skip the points that have been already discussed so we can
Yes, yes,
squeeze in Atif's case. Otherwise, we'll get stuck on the.
Yes, sir. That's it. Start sharing. Is it visible?
No,
No.
but we're seeing only your folder, but not the slides.
Okay.
Yeah. Is it opening on the cloud? I think it's not opening on the cloud.
Sure. Okay. No, it's downloaded in my Mac. It's
So
being here.
you have shared the folder. You might need to reshare the screen as a presentation.
Okay, I'll do it.
Log out and log in again. Yeah.
Share the screen.
While Nishant is reading up, Hriday, maybe we can tell the audience about the fellowship program that's coming up, the online certification fellowship program. So we plan to have this long course, like a 12-part or a 10-part course, where it's going to be a structured program on learning scoliosis surgery virtually, which will include lectures right from the base going to the advanced, and we have the whole faculty, pitching in, and we're going to try and incorporate some videos and stuff. We plan to start this in the first week of February. It's a paid, registered program, and we'll send everyone the curriculum as well as the registration links. It's an online certification course under the aegis of the Pediatric Spine Academy. We make sure that we'll send this to everyone. Ortho TV, of course, is a part of it. Medtronic has sponsored it, and VR Spine is a part of the group. Thanks, Hriday. Nishant, any luck?
No.
Okay. Do you want Atif to quickly go through his case? I think it's a simple one while you're setting up. Atif,
Yes, sir.
something's echoing. Someone's echoing. Nishant, you okay if we ask Atif to, while you set this up?
Yes,
Atif's
sir.
case is
Yes,
very quick. Because it's the case we are going to be operating tomorrow at Vadia. Atif, if you're there, can you share your screen and unmute yourself?
I have Nishant's presentation. If you want to share, I can share.
Then why don't you share Hriday? You share it, no?
It should work. I just saw that.
Hriday will share your presentation, Nishant, okay?
Yes, sir.
Yeah.
You can see the screen, right?
Yes.
Yeah. So, good evening, one and all. I'll be presenting a case of a 15-year-old post-menarche female whose deformity was noticed at 11 years of age, and she was managed conservatively for quite some time till 15 years of age. Now, she has presented to us with this X-ray, where her shoulders seem to be balanced, and her right-sided loin crease is more. Next. Yeah, these are her bending images. Her main thoracic curve was around 66 degrees, and her thoracolumbar or lumbar curve was around 41 degrees. We classified this curve to be at 3C type. Her lumbar curve was getting corrected on the left bending images, so it was quite flexible. Next. Her right-sided rib hump was very visible, and it was quite exaggerated. So then next, these were the two big questions in front of us: whether to go anterior or anterior plus posterior, or only posterior, and whether to do only selective fusion to save levels and achieve the balance, or to address both the curves. The child was a gymnast. So with the next, with the advent of pedicle screws and all, the importance of anterior releases has lowered, because we can get all the correction with the posterior, all posterior fixations and fusions. Plus, there is an added advantage that the anterior scar, which is an ugly scar, won't be there. So we decided to go all posterior. Next. With all posterior, we now had to select which levels to fuse. So we were at the stage of selecting the LIV. Next. Yeah, we can skip this. This is another case. We can go. Yeah. Next. Yes. So this is the X-ray. Next.
What is the
Yeah,
lumbar
so
curve
these
bending
were the
down to?
bending images. On closely looking, the apical vertical translation of the main thoracic was more than the lumbar curve, and the cobs of main thoracic was more than the lumbar curve. But the apical vertebral rotation of the lumbar curve was still higher, which was not getting corrected even on the traction films. Next. And the rib hump was also actually very high. Next. So then the radiology was against selective thoracic fusion, but the clinical picture was that the patient was well balanced, and also she was a lean and thin, not an obese patient. So then we decided that we'll select the LIV under anesthesia. Uh, Here I would like to ask the faculty, sir, is it okay to leave the decision of deciding the LIV after getting the patient anesthetized, or we should have our plan fixed before we go in for the surgery?
Ajay?
I would always prefer to get it done without anesthesia, but I may go one level above or below, depending upon after positioning prone, especially when you're thinking of L4 and the L3 aligns together, the rotation of L3 comes down. I would do that. But to do a selective fusion or not selective fusion, I would not make a decision on table.
Arjun?
Okay. She's on omega films.
Direct films. I think
Arjun is
everyone
in
sees.
Maunavratam.
Huh?
And what will be the optimal correction levels, sir? I mean, the once we have selected, how do we know that the correction that we are getting is the optimal correction? If we undercorrect, then we might think of add-ons. If we overcorrect, then we might think of decompensations. So what would be the decision for optimal correction levels?
The decision should be made on erect film, because you may make a mistake if you try to cheat, with the patient prone under anesthesia.
Okay.
I mean, you can't take an on-table decision. Usually, it's a decision which you take preoperatively.
Yes. Yes.
So, sir, one question. So, like the previous case and this case, the main difference in the bending films was the rotation correction that we could get. In the case Dr. Sherwin showed, the rotation even corrected. It was almost the pedicles could be seen right bang on in the bending film versus here we cannot see them. So, how significant it becomes while planning. So is that more important or the correction of the bending film more important when we plan the surgery?
This is
Can
a
I
younger child
check,
also.
please, Nishant and Arjun? Can you go ahead, Arjun?
It's a younger
Arjun,
child also. No? This is a younger child. It's a younger patient.
can you go back to the X-ray, Hriday? One slide before. We can have that in front of us when we are thinking.
Yes.
You can take away one more slide before, so we can just see the big films. Yeah. I think the lumbar curve is snobbish and she has a lumbar crease also.
Yes. The crease is significantly there.
The thoracic curve is also quite a large entity. It's not a small, easy peasy flexible curve.
I would do both curves.
Same here.
LIV, guys.
L3.
Ajay?
I will see in the traction films whether the L3 aligns. If the L3 aligns, then I will go to L3.
Yeah, I'm also tending to agree L3 or L4. I'm not too sure. Because the L3 remains rotated. I'd love to stop at L3, but I'm not sure. Today?
And it can here in bending field it does reach the at least touched vertebra, so L3 can be planned because again the L4 goes in the other direction. L3 is the apex, so maybe.
But I think the whole faculty agrees that STF is probably not a good option here.
Unless the patient is willing to take the risk, because if she's a gymnast, want to get ahead, wants to do certain things, still it's an option. I don't deny that it's not an option, but the chance of failures are higher.
Nishant?
Yes. Next. So even after positioning, there was a greater amount of residual increase there. So we went ahead and next went the full hog. Next. So we went all posterior T3 to L4, including both the curves. And
It's L3, I think. No?
4. We went till 4.
3, 4.
3 to me.
Okay. Next. We can go till last slide. So multiple osteotomies are always done with the redundant ligamentum flavum taken out and the lower part of the lamina is also taken out. But then it ultimately ends up to doing pontes rather than just posterior column, like only the facetectomies. Next.
The BVR also. And some fancy system we have used, I think.
Yeah, which system is this? Is it Indian one or what?
Fine
No,
art.
Fine art, huh?
Like maybe.
Yeah, it's a spine art.
Yeah. I think this is Thane.
See, when the curve is, if you want to derotate, using a titanium rod has got an advantage. If you put a spanner at the end of the, it's very easy to derotate
yes.
rather than rotating with the rod holder.
Correct, yeah.
Good correction.
But the sagittal profile would have
hypokyphotic. Yes. So this was the ultimate correction.
Okay.
Could she go back to gymnastics?
Yes, she went full back. She's doing aerial yoga now after say 5 years of post-op, and she's completely happy with it with no complaints.
Will the video play here? Just give
I'll try,
people
sir.
a perspective on. This was a child who I mentioned that we went all the way down, but yet she's fully flexible, mobile. She does that particular kind of break dance, and she sent a video, put it up on Instagram. So the whole thing about a gymnast needing a STF, I think breaks down in my head because he's now lived 5 years as a child who's super
I
active.
told you, she's a child. Wait till she's 30, then you see the difference.
Yeah, no, I mean the one of the arguments to do STF is to give them a good childhood, right? Like to
Right.
let their childhood be active. Look what she's doing as a child. So we're not even yet talking about back pain when she grows older. Like this is stuff that this is all post-op.
The video is playing, sir.
Yes.
Yeah, it's playing.
Yeah, yeah.
Okay. I think
Right.
it's 1.5 hours more and more.
Quickly, um, yeah, you can go off. Atif, quickly, can you put up your case? Because there's just one point in that case which we'd like everyone's opinion on. Atif,
Yes, sir. Yes, sir. I'm just sharing. Sir.
the last case will wind up in 5 or 10 minutes. Yeah, we can see your screen. Can you go on slideshow? Go on slideshow.
Good evening. So I'm presenting a case of a 13-year-old boy. Is presented to us with the deformity of back, but the deformity was first noted at 6 years of age. So the curve was gradually progressive, and he has have no pain, no neuro deficit or no involvement of any neurology. On examination, right shoulder and scapula are at higher level. There was right rib hump present. Thoracic scoliosis with convexity on the right side was there. There is waist asymmetry. I'll share the
Show
figure.
the clinical pictures, no? That'll be more relevant. Yeah.
So this is the clinical picture of this patient. So there is shoulder imbalance, there is scapular prominence, then gross waist asymmetry and truncal imbalance, we call, and right-sided rim hump is also there. So on sidewards, this is the patient's look. So coming to the X-rays, the erect film. So the thoracic cobs is 67 degree and the lumbar angle is 30 degree, and which on traction and right bending is correcting up to 52 degrees, the thoracic cobs, and the lumbar is close to 2 degrees.
Is he hyperkyphotic in the thoracic spine? Hyperkyphotic?
Yes, sir.
And he's not syndromic. He's
He doesn't look like classical idiopathic. You look at the way from the front he stands. There is some. It's not a very classical of.
yeah, I agree. I fully agree. Huge rib hump, sloppy child. You can see him like falling over on the sagittal profile also. And he's like swayed off in that front view.
We have done all this, all the like other departmental review also.
But everything is negative, no?
Yeah, everything is negative. That's why with the ruled out diagnosis is idiopathic, which may be with the early onset.
So go back to the X-ray and maybe let's talk about the UIV LIV here. It's a large cob.
One.
The lumbar seems insignificant, right?
Yeah.
So, and your last significantly touched vertebra seems like L1.
Upper one, maybe, I don't know whether it's D2 or D1 where the CSVL touches. It looks like bent significantly. Maybe I will, even though the right shoulder is up, I may still go up.
UEB for me would be like 3, I think, not even 2.
Yeah, I
And
can't make out
Arjun,
here.
your UEB? For Ajoy, it's T2, right?
I'm not sure it's T2 or T3. I'm not able to visualize it clearly. Somewhere around that point.
Arjun, UEB?
D3, I was thinking D3.
T3. And
D3 to 1.
1 is the LSTV and 2 is the STV. I mean, stable vertebra, SV.
Yeah.
So the rotation of L1 is very favorable. And I think on the bending films also L1 is good. The slight controversy would be the amount of kyphosis and when you draw that, sagittal CSVL, can you draw, Atif, if you have the capability? There's a sway back almost seen. So on the sagittal view is the
L2.
L1 stable. Like I'm erring towards L2. Given his clinical sloppy picture, and in my mind, going to L2 instead of L1 is not going to harm him in any way in the
Yes.
longer run.
Yeah, good
Same
decision.
Atif, are you able to draw that line? ऐसे नहीं. You can't. You can go off show and just transfer one of the lines there. That blue line on the left picture, just do a copy paste and agreed, no? L1 is falling way back.
Yeah, L2.
Yeah, PowerPoint show, please. So 3 to 2 for me. Hriday?
Yes, sir. 3 to 2. Or so
Not
I
1.
was thinking the same. Maybe for lumbar we can go L3, but L2 should be fine. L3 is the most stable, 2 or 3, whatever. Not above L2 for sure. This is
Arjun?
the lateral X-ray that is going to
Right,
define
L2 is better,
our instrumental
definitely.
segment instead of the AP X-ray.
L2 safer, no?
Yes.
Perfect. Ajay, any comments?
No, that's fine.
Atif, any comments? Do you
Tomorrow.
agree with this plan
Yes, sir. Yes, sir.
and go for full correction because it's a single curve? Perfect. Thank you, Atif. So I think
Has
we have
been done, operated or
No, tomorrow morning.
tomorrow?
Yeah.
Okay.
Awesome. So I think it was a superb webinar. I think I learned a lot personally because everyone's collective experience is so unique and different. And thank you for the lecture, Ajay. I think it was a crack lecture. I want to borrow that from you and keep seeing it again and again. And of course, thank you, Hriday, for organizing this and the case you presented. Thank you, Nishan. Thank you, Sharvin. Thank you,
Thank you, sir.
and of course, Arjun for participating, Appaji and Amit Jhala. So it was a lovely webinar all in all. I think this year's webinar series is going to conclude now. We're going to have a 2-month break because there's some activities happening. We're going to see the Pediatric Spine Academy at the PossyCon in Ahmedabad in January. And then we're going to see them in the AIMS deformity course. We're going to be partnering with them. And then in February, we will start the online fellowship of the PSA. So we'd like to see you there, as many of you as can get in. So with that, I think it's a good time to, call it quits for today. And thank you for being there and go through the YouTube recording of this video, which is going to be on Ortho TV. So thank you, Ortho TV, for partnering with us and playing our recordings over and over. With that, I'll say good night. Thank you.
Good night.
Good night.
Good night, sir.